The toolkit for safer tracheostomy care really came about as a direct response to COVID-19 pandemic. What we realised from global experience was that there was a growing number of patients who were on increased and prolonged ventilation care, and those patients need to be weaned off that ventilation care if you're taking them out of an intensive care unit. So what we realised very quickly in the pandemic was that a number of clinical teams who were not familiar with dealing with tracheostomy patients would be caring for this cohort of patients. So it was felt that there was a need for a very simple toolkit that would help guide and support those clinical teams in how best to manage a patient with a temporary tracheostomy in place. And that's really where the development of the toolkit came from. So working with Brendan and the clinical national team and the patient safety collaborative, we pulled together a rapid response to development of this toolkit, which are 3 simple interventions, and both Health Innovation Manchester and our neighbours at the Innovation Agency, Andrew Cooper and myself, Jay Hamilton, led this national piece of work so that it was rolled out across all 15 AHSNs. We recognised just how overwhelmed these teams were, so we didn't try to use their time in a way that would add increased burden. We went through the critical care networks to communicate where the toolkit was cited, how to get hold of it, how to get help and support, but it was very light touch so that we weren't adding a burden to those teams, which I think was a critical part of the success. So the introduction of such a simple tool with 3 key areas of safety that really do ensure that that patient is looked after in a safe and well-managed way was vital. And certainly the feedback we've had from those teams is that this is really easy to use, it's really easy to access, and with very little intervention, they're able to do things in a way that they feel confident and competent to do. We have helped a lot of teams who would have been nervous, unfamiliar, inexperienced in dealing with trachees to deal with them with more confidence and competence. So that's been absolutely fantastic. I think one of the things that I'd reflect on is how quickly Andrew and I were able to mobilise workstream leads from all 15, pull them into weekly spaces, talk to them about their shared learning, get a baseline, then start to really work out how to get information across to teams. And if you think that that's been done in the space of 12 weeks, you know, with people under incredible pressure at the most pressurised part of the system, the ICU and step down teams, they're the ones that have been in everybody's thoughts and thinking in this pandemic, and yet we've managed to do what we've done and show demonstrable improvement in a number of AHSNs where only 1 or 2 interventions were being used, now all 3 across all of their areas. So a really rapid sort of journey that we've been on with some real good quality outcomes that we can measure, and I think that's testament to how well the PSCs within the AHSNs collaborate with their systems. Going forward, it's about the quality of the use of those interventions, so we'll take a look a bit deeper as to how we can support the actual use of the 3 signs at a level of quality improvement.